Hi guys, today I'm going to be talking about acute stroke activation. So this is any sudden onset focal neurological symptoms within the past 24 hours. First thing you do is get a history, you get a last seen well time, not when the symptoms were noticed, but when they were last witnessed to be normal. You get information on anticoagulants, antiplatelets, creatinine clearance, any allergies to medications, make sure they get their code status, what is their DNR, DNI status. If they have any premorbid disabilities such as walking with assistance or bedridden, this makes you more likely for stroke. You get any contraindications of TPA or TNK. There's a long list. Make sure you go through the checklist. Basically, there's relative and absolute contraindications. The absolute contraindications are any signs of active bleeding. Relative contraindications are any propensities to bleed. You can think about what kind of things those might be. For example, active GI bleed, absolute contraindication. Anemia, relative contraindication. Let's see, elevated PTT, relative contraindication. Active trauma and active bleeding, that's absolute contraindication. All right, physical examination. So hemiplegia, this is weakness, paralysis affecting half of the body. Any lateralized facial weakness, focal sensory deficits, and dysfunction of speech, vision, and hearing. The most predictive findings include facial paresis, arm drift or weakness, and abnormal speech. So you've noticed these things. Next thing you do is activate code stroke. What you do is you have to evaluate at the bedside, obtain an 18 gauge peripheral IV, place the patient with a travel monitor, get the ABCDEs, airway, breathing, circulation, disability exposures, and vital signs to see if they're stable. Get an EKG to rule out heart attack or any atrial fibrillation or things that could be concerning. Telemetry of the past 24 hours, see if they had any periods of bradycardia, tachycardia, sustained versus non-sustained, atrial fibrillation, stuff like that. So you get a finger stick blood glucose. This could be like hypoglycemia. We place a bed at 30 degrees, and the next thing you want to do is you don't want to lower hypertension if they're likely to have a stroke unless the blood pressure is greater than 220 over 120, if they have any acute coronary syndrome or intracerebral hemorrhage. Hypotension has a pretty poor prognosis with stroke. We'll talk about that later, but next thing you want to do is confirm the weight and MRI contraindications. So in the orders, you want to order stat CTA head and neck, and apparently the CTA includes non-contrast head CT, but yeah, in some hospitals you have to order both. All right. Next thing you want to do is if the patient's unable to receive the contrast, the stroke team may consider stat MRI plus or minus MRA. So basically, why would you do that? Like the patient has renal failure or any known allergy to contrast or something like that, then the stat MRI plus or minus MRA. Another thing is if your hospital has ability to order MRI right away and it's freely available, that's actually more sensitive than the CT is. So that's a game time decision based on what resources are available to you. Next things, so stat labs. So you order finger stick blood glucose, like I said, CMP, CBC, PT, PTT, INR, type and screen, venous blood gas, troponin, urine analysis, urine culture, tox screen, and anti-epileptic drug levels, and beta HCG if the patient's a woman and less than 50 years. So another thing to remember is nursing performs NIHSS scales at the bedside. There's a validated scale that predicts stroke. Make sure you ask for the nurses to be doing that if you're suspecting stroke. Another thing to work up is lipids, A1C, TSH, ESR, CRP, RPR, HIV, carotid ultrasound, EKG, transthoracic echocardiography, telemetry less than 30 days, and you can do an MCOT or link. These are basically cardiac devices that monitor the rhythm over a series of days to see if they have any recurrence of arrhythmia or anything like that. Let's talk about the pathophysiology of stroke. So basically 85% of strokes are ischemic. If you have a stroke, it's most likely ischemic. Hemorrhagic is 15% of strokes. Intracerebral hemorrhage is 10%. Subarachnoid hemorrhage is 5%. I know these numbers don't add up exactly to 100%, but these are just relative numbers. So let's talk about ischemic causes. So ischemic causes could be a cardioembolic stroke. So you suspect this if you have major vessel occlusion, such as ACA, MCA, PCA without significant vascular disease in the past. If there's infarcts in multiple vascular territories or cerebellar stroke, any arrhythmia, if they have a known left atrial or left ventricular thrombus, if the ejection fraction is less than 35%, if they have a TTE with bubble study if less than 60, What did I hear? So yeah, so the bubble study is if they're less than 60. Telemetry you follow for 30 days. If they have a PFO on the bubble study, then if they're less than 60, you can attempt to close it. Next thing is you can transfer to long-term anticoagulation at 2 to 14 days. If you're concerned, then you can delay 2 to 4 weeks. All right, so let's talk about carotid stenosis. This is another sign type of embolic stroke. So you suspect when the carotid stenosis is present on the ipsilateral side, you'll usually find this on MRA or CTA. But basically, carotid stenosis is highly associated to atherosclerosis, or basically hardening of the arteries due to atherosclerotic plaque. If the patient has a history of hemorrhagus fugax, that's basically like a ophthalmology, whatever, the eye, if they have a cholesterol plaques in the eyes and a sudden loss of vision. CTA versus MRA, I already talked about that. So carotid ultrasound could also find out how bad the stenosis is. If the patient has a history of stroke, TIA, and either stenosis greater than 50% or having high risk plaque features, you can consider revascularization within 2 weeks of symptoms. You can consider temporary anticoagulation, consider induced hypertension if symptoms fluctuate with blood pressure. All right, so let's talk about infective endocarditis. So you suspect this when there's an unexplained fever with stroke or patient with valvular disease. The workup is blood cultures followed by TTE, followed by TEE if negative. You can order CTA head plus or minus conventional angiogram to identify mycotic aneurysms that increase the bleeding risk. So the therapy for this is immediate antibiotics. TPA is actually contraindicated in this patient. You do early cardiac surgery if the stroke is small and non-hemorrhagic. Delayed surgery in 2 to 4 weeks if large or hemorrhagic stroke. You avoid anticoagulation or antiplatelet without separate indication, which gives the patient high risk for hemorrhagic conversion and increased mortality. Other type of embolic stroke, so you have carotid and vertebral dissections. So you can suspect this when the patient is less than 60 years old, or posterior circulation stroke in patients without risk factors. If they have neck pain, if they have headache or Horner syndrome, trauma or a recent chiropractor appointment, or coughing spells. So the diagnostic workup for this is CTA versus MRA with T1 fat saturation. So you can also consider connective tissue diseases such as Marfan's or fibromuscular dysplasia. These are basically problems with collagen. So that can basically make your arteries more susceptible to dissection. So next thing I'm going to talk about is hemorrhagic stroke. So remember, this is a different type of stroke. 15% of strokes. The causes are trauma, ruptured aneurysm, arteriovenous malformation, subarachnoid hemorrhage, interparenchymal hemorrhage, also caused by hypertension, cerebral amyloid, a tumor, most common cause with metastatic breast cancer, lung cancer, melanoma, RCC, choroid plexus malformation, thyroid carcinoma, corticovenous or venous sinus thrombosis, hemorrhagic conversion of ischemic stroke. This hemorrhagic conversion of ischemic stroke is what you should remember. That's most likely from hemorrhagic stroke. The ruptured aneurysms are more common. Hypertensive intraparenchymal hemorrhage is also more likely. But all right, how does this present? So you have an acute focal neurological deficit plus or minus progressive loss of consciousness, nausea and vomiting. Subarachnoid hemorrhage, you'll have a thunderclap headache, nausea, vomiting, meningismus. What is this? This is basically a Brudzinski sign with the patient has their neck flexed. They experience flexion of their lower legs or pain. Epidural or subdural hematoma. Status post-trauma, there's a lucid interval with epidural hematoma, intraparenchymal hemorrhage. There's a focal neurological symptoms often with the headache. So the test for this, so it's the same thing except CTA of subarachnoid hemorrhage or intraparenchymal hemorrhage, stat neurosurgery of subarachnoid hemorrhage, subdural hematoma, epidural hematoma, otherwise neuro. So you elevate the head of the bed to 30 to 45 degrees to reduce intracranial pressure and prevent aspiration. Next thing is blood pressure control is very strict in hemorrhagic stroke. You want to keep the blood pressure less than 140 with arterial line monitoring. Use IV labetalol, nicardipine, clebidipine, or esmolol. You use a less restrictive blood pressure goal for patients with systolic blood pressure that's at their baseline of 180 to 220, or 25% reduction if systolic blood pressure is greater than 220. For aneurysmal subarachnoid hemorrhage, you want to give oral nimodipine. All right, so we talked about the pathophysiology. Now I'm going to talk about the acute stroke management. So if it's an ischemic stroke, you give IV thrombolysis, either TPA or TNK, 0.25 milligrams per kilogram. The max dose is 25 milligrams. TPA is given as infusion. TNK is given as bolus. TNK is actually now preferred thrombolytic. What does TNK stand for? Is tenecteplase. And, one sec. Yeah, tenecteplase. Okay, tenecteplase is now preferred thrombolytic. So when do you use this? So first of all, there's inclusion criteria and then there's exclusion criteria. Make sure you look those up. So like basically if they don't have any contraindications, and they would most likely help be recovering from this after intervention. If the last seen was less than 3 hours, IV, TPA, or TNK within 60 minutes. Also 3 to 4.5 hours, you use TPA, TNK, but there's relative exclusion criteria such as age greater than 80, anticoagulation if the NIHSS scale is greater than 24, history of both stroke and diabetes mellitus too. If they have a wake-up stroke or unknown onset. So what is a wake-up stroke? Wake-up stroke is basically the patient wakes up and is exhibiting symptoms of a stroke. In this case, you basically want to assume that their last seen was before they slept. In that case, you want to give IV TPA if the lesion is less than 70 milliliters without flare changes. So go ahead and ask your radiologist about this. But okay, so let's talk about intra-arterial therapy. What does this mean? It's basically any interventional neurologist who goes in and has contrast and either does thrombectomy or thrombolysis. So this is in patients with disabling deficit and large vessel occlusion with lasting less than 6 hours all the way to 24 hours based on the imaging criteria. And what is the rule of thumb here? So basically, if there's something you can fix that would the benefits greater than the risk, you go ahead and do thrombolysis or thrombectomy, otherwise known as intra-arterial therapy. All right, let's talk about blood pressure goal. So it says low systolic blood pressure less than 150 is associated with poor outcome. Why is this? This is because in a stroke, there is ischemia of the brain because the arteries are not perfusing the sites of the brain, and the umbra, which is the site of the ischemia, and the penumbra, the area around it, is basically getting underperfused as well. So what you want to do is you want to you want to have a high enough blood pressure essentially that they can perfuse their arteries, perfuse the areas in the brain through collateral circulation. So if the patient is a TPA TNK candidate, the goal blood pressure is less than or equal to 185/110 prior to thrombolysis. You treat stat if higher. The first drug is labetalol or nicardipine. The goal blood pressure is less than or equal to 180/105 after TNK TPA for 24 hours. If no TPA or TNK, the goal blood pressure is less than or equal to 220/120 for 1 day. Gradually reduce blood pressure goal subsequently. If the patient is anticoagulated, the goal blood pressure is less than or equal to 180. If active cardiovascular disease, discuss with neuro. Next thing is you monitor the neuro exam after the stroke. You want to do Q4 NIHSS checks, especially if the symptoms are worse. If the patient's getting worse, first thing you can do is lay the bed flat, give IV a fluid bolus, stat page neuro. You want to consult PTOT, speech language pathologist, and PO until bedside swallow eval is clear. Keep euthermic and euglycemics, fasting sugar less than 180. And next thing is post-intervention, you want to start antiplatelet and PT prophylaxis. What is this? So this is basically aspirin 325 milligrams followed by long-term antiplatelet or anticoagulation for large ischemic strokes. You start DVT prophylaxis if it's ischemic stroke. So this also includes clopidogrel. This includes heparin, GTT, and apixaban, rivaroxaban. Correct me if I'm wrong, but I think, yeah, that's what you do. But all right, so let's talk about the inclusion criteria for TPA-TNK. So the inclusion criteria are severe or disabling neurological deficit. Second is age greater than or equal to 18. Third is last seen less than or equal to 4.5 hours, or wake up stroke. Exclusion criteria is anything that causes increased bleeding. Intra-arterial therapy, we talked about this. So this is inclusion criteria is NIHSS greater than or equal to 6, last seen less than or equal to 24 hours, age 18 to 90, minimal to moderate disability as determined by modified Rankin scale. It's a calculator, it's a questionnaire that you could fill out. Or if the life expectancy is greater than 12 months. Radiologic inclusion criteria include ICA, MCA, M1, M2 occlusion, again, major vessel disease, major vessel occlusion, basilar or vertebral occlusion, or small infarct core volume. Basically, if there's something you can do that's fixable, you should do it. The exclusion criteria is anaphylaxis to contrast or acute intracerebral hemorrhage. So next, let's talk about things that present like a stroke but aren't. So MINT, M stands for metabolic, so anything going on with glucose, sodium, uremia, toxic metabolic encephalopathy, thyroid disorders. MELAS, which stands for mitochondrial encephalopathy, lactic acidosis, hypoxia, hypercarbia, infection such as Bell's palsy, meningitis, encephalitis, vestibular neuritis. Then we have neurological such as migraines, TOTS, paralysis, post-ictal, functional neurological disorder, multiple sclerosis, myelin, oligodendrocyte, glycoprotein neuromyelitis optica spectrum disorder, toxins and traumas, toxins and traumas. So anything, okay, so high yield radiology. So if it's a hypodensity, it's an ischemic infarct. Hyperdensity is a hemorrhagic infarct. If it's a chronic lesion, it's also probably hyperdensity. What does hyperdensity mean? Hyperdensity is basically something that is very bright on the read. Hypodensity is something that's very dark. So you can localize the lesion based on what territories are infarcted. So you should go through that, ACA, MCA, PCA, and stuff like that. And that is my rundown on stroke.